She attended medical school in San Diego and did her residency in internal medicine and pediatrics at Cedars-Sinai Medical Center. And you may recall or last month's meeting, Paria Hasuri, who was our guest, spoke highly of Dr. Weimer, as Dr. Weimer did an intro to Paria's book. So they know each other well and are coworkers and friends. Following that, as a primary care physician for both adults and children, Dr. Weimer has a deep commitment to caring for transgender and gender diverse communities. So much so that in 2016, she founded the UCLA Gender Health Program. And I want to take a step back and really acknowledge you, Dr. Weimer, as being the founder of such a program. It speaks volume of who you choose to be as not only human, but also how you choose to show up with your work and with your passions for the communities that you really choose to serve. You're an embodiment of actions expressing priorities, and I want to acknowledge you for that on behalf of not only our chapter, but my family and the larger family of the transgender community and parents and caregivers. So thank you so much for choosing to make that your life's work. And using your skills and your knowledge to be able to really help each of our individuals and loved ones be who they are. And so thank you. Outside of Dr. Weimer's amazing body of work in UCLA Gender Health, she also enjoys reading, doing puzzles, spending time with her family, and being active outdoors. And so from that, Dr. Weimer, take it away. Thank you for being here.
Can everybody please shut off your videos? And then I'm going to hide the videos for the recording purposes.
Isabel, I wanted to say thank you very much. That was such an incredible introduction. I am remembering that when we talked just before this meeting, we wanted to have a moment in recognition of Transgender Day of Remembrance. Did we want to do that now or following the presentation?
You know what? Absolutely. If you, we don't need to change anything, but from here, thank you so much for the reminder, Dr. Weimer. I will probably just take a minute to do that, if you don't mind.
Again, that would be great.
Yeah, November 20th. So this Friday is Transgender Day of Remembrance. And we want to honor this by simply taking a moment of silence before we begin Dr. Weimer's presentation. And so just take time from wherever you are in your home or at work or in your car, from wherever you're joining us, and to feel your breath enter and leave your body. And just honor in silence the lives of those in the transgender community, lives that were lost to violence. From wherever you're joining us, take one more full cycle of breath, a full inhale and a full exhale. And honoring the resilience and the courage of the trans and non-binary community, and honor them by being here and advocating for them. Thank you. Dr. Weimer, over to you.
Thank you, Isabel. So I'm very appreciative for being able to be here today and for allowing me to have some space here. I wanted to tell you a little bit about my own journey in coming into this, because I often get the question about why do I do this type of care? And I recognize that I come into this space with a lot of privilege. I am a cisgender, heterosexual white woman, and I constantly try to keep that awareness about me and really practice cultural humility in learning from the folks that I am doing my best to care for. Through the course of my primary care years, I had a series of patients who were transgender, whose family members were transgender, and I found myself very moved by their experiences, by their dedication to trying to live their best authentic selves and to the courage that it takes to do so. And I heard from them that it was a relief to feel comfortable in a medical setting. And after having enough of these encounters, it became clear that this needed to be formalized and findable so that we really could create a space where people knew they could come to get high quality, sensitive healthcare. And so in 2016, we launched the Gender Health Program at UCLA. And I'm here to talk about not just that program, but how our entire health system has really implemented a whole variety of initiatives and endeavors to improve the healthcare of the LGBTQ population in general, and also transgender and gender expansive folks specifically. Now, as many of you will be aware, there are innumerable barriers to care that transgender individuals have faced historically. One of the best descriptions I've seen comes out of the 2015 US Transgender Survey, which was put out by the National Center for Transgender Equality. And this is an anonymous online survey that received about 28,000 responses. Interestingly, a third of whom identified as non-binary. And in this survey, a third of the respondents who had seen a healthcare provider in the past year reported having at least one negative experience specifically related to being transgender, such as verbal harassment, refusal of treatment, or having to teach the healthcare provider about transgender people in order to receive the appropriate care. We know that facing discrimination, harassment, or direct refusal of care has historically been very common for the transgender population. And I think it's important for us as a health system to keep this in mind, because we have a historical pattern to really make amends for. And we need to keep in mind that folks may be coming to us with a lot of distrust and guardedness because of prior experiences that they've had personally or that the community has had. Finding knowledgeable providers remains a very significant barrier to care. And folks often talk about needing to educate their providers or being refused care because the provider doesn't know how to care for them. And we also hear a lot of stories about chronic microaggressions that are really coming from cis-normative expectations. So when we are creating a health system that really has a traditional binary expectation around the way that we interface with gender and gendered language and bodies, those experiences, each one of those little microaggressions can build up, and a single one of those experiences can be enough to have a patient turn away and mistrust a system. And this has been very important for us to remember, because we're a huge system, and making the entire care system more aware is a big undertaking, and it is requiring constant evolution and responsiveness to what we're hearing back from our patients. One of the, I think, most impressive endeavors was that our current president, Janice Spisso, shortly after she came to UCLA in 2016, convened the LGBTQ Equitable Care Committee. And this committee was really tasked at looking at the entire health system and how we could leverage it to deliver compassionate, inclusive, and equitable care to the LGBTQ community. And the committee was broken up into several different work groups looking at different aspects of our system and our research, our facilities and how they were built, our staff and how they're trained and educated, our clinicians, our providers, residents, medical students, and how they're educated. And we really made quite a significant number of changes out of the work of this Equitable Care Committee, which is still ongoing and evolving. We have a number of policies that have either already been in place or have been implemented over the last few years. The first one that I just want to highlight is our patient rights policy, which comes from our Office of Patient Experience. And many of us may be aware that when a non-discrimination clause is used in a policy that includes non-discrimination on the basis of sex, this has been variably interpreted as whether or not this includes explicitly protections against discrimination on gender identity or sexual orientation. And many of us are probably also aware that the Supreme Court over the summer did rule in favor of this term sex being inclusive of sexual orientation and gender identity as it applies to employment law. And we still don't have a definitive determination in regards to healthcare, but I do see that coming. However, at UCLA, we have always had sexual orientation and gender identity as part of our specific non-discrimination clause. So that is distinctly spelled out in our patient rights. We also drafted a policy which has now been implemented for about 3 years, looking at specific areas of our health system where there may be specific challenges that the system faces and transgender folks face in interfacing with the system. And one of the most common ones that comes up is if a person needs to be admitted to the hospital and the room that's available is a room that 2 patients can share, how do we ensure that that matchup is comfortable from the perspective of gender? And so this policy explicitly states that folks will be assigned to rooms based on their self-identified gender and or their preference, regardless of whether that self-identified gender is perceived to match the gender of the other person in the room. And it goes further to say that if the other person in the room has any concern about that or any objection, it is that individual who would be moved to a different space. So we're not going to displace somebody because they're not being received well by another person. We have developed a training module which really helps our staff understand some of the common issues with language, gendered language, with assumptions that we make about people, about their bodies, about their behaviors. And this has been available for about 3 years, and we're moving now to making it required training throughout our entire health system. And as you can imagine, in March, we started leveraging a lot of telemedicine. And still currently, I would estimate that about 40 to 50% of our visits take place via telemedicine. And this has been an incredibly useful tool in being able to provide gender affirming care. Because, you know, prior to this, I would have folks that might drive 3 or 4 hours to come see me. And now when we can leverage having at least a significant part of that care occur via telemedicine, it's been an incredibly useful tool. And we definitely foresee having this be a big aspect of our care going forward, even when the pandemic restrictions get lifted. One of the issues that does sometimes arise is that telemedicine restrictions are tied to our state licensure. And so typically we can only see patients who are in the same state that we are licensed in and only see them from within that state. Because of the pandemic, those restrictions have been lifted across the country. So currently we're able to see folks even who are out of state, but we do anticipate there may be some licensure restrictions that come back into place. And, you know, this is sort of a smattering of some of the things that have allowed us for the past 3 years to be designated as an LGBT healthcare equality leader by the Human Rights Coalition's Healthcare Equality Index. And this is based on a very extensive assessment of what services are available, how the institution supports folks moving through those services, what sort of research endeavors are going on, et cetera, et cetera. One of the, I think, most important things that we can do is make sure that the main tool we have when we're delivering healthcare, which is our electronic health record, really displays the patient in the way that they want to be seen. And so I've put up here, this is from our training playground. This is not an actual patient, but a mock-up of what our current storyboard looks like. So we are required to have the legal name on file. And by legal name, I specifically mean the name that's on the insurance card so that things can match up from a billing perspective. But we're trying to make the name in use be really the most viewed and prevalent name. And so with this individual, their legal name is in the header, but their name in use is in quotes. And we're training all of our staff to look to the name in use and use that name. The gender that's displayed in the header is actually linked to the gender identity. And you can see that we have a field for pronouns as well. When we hover over that, we can see more of a detailed breakdown of the different sex and gender information that we capture. So we have our gender identity, we have our legal sex, and then we have sex assigned at birth. And as you can imagine, from a medical standpoint, it's really important for us to know all of that information, but we want to make it information that is more discreet. The other thing that's happened with this is that now when patients register with our health system, they are asked their name and use and their pronouns, and this is done universally for all patients. And in addition, when they do an electronic check-in, either for an in-person visit or a video visit, they're given what we call our SOGI questionnaire to complete. And this is the physician view, but essentially it asks for sexual orientation, gender identity, sex assigned at birth, and pronouns. The organ inventory that comes below it is something that we as providers complete, and this is in order for us to really keep track of anatomically, what organs does this individual have now so that we can make sure that we're attending to their health in the most accurate way possible. So a little bit more about some of our specific programs. I'll start with the Gender Health Program. And this one is my baby. So I'm very proud of how rapidly and robustly it's developed over this time. It's a very large multidisciplinary program now that really can provide all gender affirming services within UCLA. And more specifically, what I mean by that is, our heart and soul of the program has been a primary care medical home. So what we really want is to be able to care for patients comprehensively. And the heart of that is having a place to go where your care can be coordinated and your health can be attended to in a really holistic manner. Hormone management in our program happens either within the primary care sites or through an endocrinologist. And that's really up to patient preference. And it's also up to the specific services a patient needs. So when a patient contacts our gender health program, they go through an intake with our program manager or intake coordinator. And based on that, identify the services that they need to be connected with. So if somebody has a primary care doctor that they have a great relationship with and they're not interested in shifting that, that's great. And then they can come here just for hormone management, either through endocrinology, or we do have many patients we see in our primary care offices, but only attending to their gender focused needs. We have urology services, so we can do all types of genital reconstruction, including orchiectomy. And the urology department is the other pillar upon which our gender health program is founded. The chair of the urology department, Dr. Mark Litwin, is my co-director in the gender health program. And urology is actually also where a lot of our research endeavors are housed. So they really contribute quite a bit to this program. We have OB-GYN services, including just sort of general services, as well as specific gender affirming surgeries available. And just to be very specific about this, the folks from these departments that are seeing our gender health patients are active members of our gender health team. So they have expressed a specific interest in caring for this population, have gone through their own training and making sure they're doing it sensitively, and are very engaged in the program. Our plastic surgery department's a big player in our program. We can do chest surgery, facial reconstruction, and then sometimes the plastic surgeons also will contribute on the genital reconstruction surgeries. Our ENT department can do tracheal shaves or vocal surgery. The speech therapy department has a very large vocal therapy team that's really active with our program. And the benefit of going through this pathway is that many times we can actually get the vocal therapy covered by insurance, which is a really, really important service for folks to be able to access, but often something that they're paying out of pocket for. Our dermatology department can do laser hair removal. And again, we've had some luck with getting insurance to cover it this way. We do not have electrolysis available. And then we have fertility assistance available, both egg-based and sperm-bearing folks. And we do have behavioral health services available. There's a psychologist who's integrated into our gender health program that can really work to help connect people to resources in the community that can assist with things like statements of support for surgery authorization. And I'll tell you a little bit more about other behavioral health services in a moment. And then we have our care coordinator as a centralized point of contact. And this information that's down at the bottom is all this all goes to our care coordinator, who can help get folks directed to where they need to go. So one question that might come up is, what about kids? Do we see kids, and what services are they eligible for? And in our primary care medical home, we see patients of all ages. I think our youngest gender health patient right now is 5. And we can, support them with pubertal suppression if and when it's indicated, as well as sort of the pubertal induction hormone management. So we can do hormone management across the age spectrum. And, obviously for surgeries, for most surgeries, we do wait until they've reached adulthood, with the exception of top surgery for transmasculine individuals. So that's something we definitely see both a strong medical necessity for, and also a lot of interest in during the younger adolescent period. But services like hair removal or vocal therapy or fertility services, those are all available to minors as appropriate for what they need for their care. The UCLA Empower program, so this is one of our behavioral health programs. It's a multimodal mental health program for LGBTQ identified people of all ages. And they can provide individual therapy, individual psychiatry, and then they've developed this really impactful group resilience skill workshop for youth who are 12 to 17. And it's sort of a blend between a support group and a curriculum. So they really do work on specific skills through the course of the workshop. And then they have more recently developed a similar workshop for parents and caregivers that goes in parallel to the youth track. And actually just last week, we launched a resilience skill workshop for adults from our gender health program through the gender health program, separate from, but very, very much informed by the Empower program. And so they have their own separate contact information, but they're very, very skilled mental health providers. They can really manage some fairly complex psychiatric needs, so complex psychiatric medications, and our patients really just blossom through their care. And then we have our UCLA Care Center. So this is the Center for Clinical AIDS Research and Education. And this center has been around for decades. So it's a very well-established center that provides clinical care for HIV prevention and treatment, as well as cutting-edge research with a large number of clinical trials always going on. And I just grabbed this grid from their current clinical trials last week. So there's a lot of care going on in this area. And what we've seen over time is that much of this care has moved towards HIV prevention and then sort of how do we manage optimizing someone's health while they're living with HIV? The previous care model, 20 years ago, was just really getting folks to get their HIV treated to extend life. And now it's really more of a chronic disease management model. The other thing I want to mention is that many UCLA primary care providers do prescribe HIV pre-exposure prophylaxis. So this is a daily medication that you can take if you are engaged in high-risk behaviors that would put you at risk for HIV. That has a dramatic impact on reducing the risk of acquiring HIV. And a few of our primary care providers are also certified in HIV treatment as well. So HIV-related care does not need to happen through the care center. It can happen at a variety of sites. But the care center has been a tremendous resource in informing how we provide that care through the health system. So how would one go about finding a provider? I would say for the Gender Health Program, contacting the program coordinator, because they can talk you through, who all of the available providers are. But in general, we have created a designation, our LGBTQ champion designation. And you'll see on my profile here down at the bottom where it says LGBTQ champion. And this designation is something that providers need to request, so they opt in for it. And they need to show evidence that they've had specialized training in LGBTQ health and have had prior and are still having ongoing experience in LGBTQ health, and that they are committed to continuing to have more education about it. As we know, in medicine and in LGBTQ culture and health in general, things are constantly evolving, and we need to be constantly relearning and re-educating ourselves. So we do have a website at the UCLA health.org website that lists all of our LGBTQ champions, so folks can look there as well. And at our main call center line, when one calls UCLA looking for a provider, they know how to access this information as well. So I wanted to take the last few minutes just to shift a little bit on family, because I think what we have to provide at UCLA is wonderful and powerful. And I also think that it pales in comparison to the importance of what happens within the family unit. And I want to thank everybody here who is a family member or a friend or somebody who is supporting someone from this community, because you are making the difference. Now, some of this information will probably be familiar. We have a fair amount of research looking at the outcomes of how people do from a health, both physical health and mental health standpoint, if they have a supportive family or if they have a less supportive family. And we know that LGBTQ youth who have higher levels of social support at home and who have parental affirmation, recognition of their identities, they are much more likely to have better mental and physical health. We know that transgender and gender expansive youth who are allowed to socially transition gender have similar rates of depression and only slightly elevated rates of anxiety when they reach later adolescence and adulthood than their same age cisgender peers. And their overall well-being is similar or even better than their same age peers. So providing this home, particularly to folks who are providing this support at home, particularly to folks who are young, has a tremendously impactful effect on their health going forward. This is another study, the Family Acceptance Project, and they've created these infographics that I think are great that show this very direct correlation between the level of family acceptance and the likelihood that a youth will perceive that they can be a happy adult. And likewise, we know that folks who have a lot of rejection at home have markedly higher rates of suicide attempts. So what happens in the home is really important, and we spend a lot of time with our families really supporting parents on their journey and sorting out their own responses to everything that's going on, because we can't take care of a child well if we can't take care of the parents well. And we know that child will do better if their parents are feeling confident and comfortable with the care that they're receiving. I wanted to share, I was just at a conference called the World Professional Association for Transgender Health, where they have a biannual scientific symposium. And so I was just there 2 weeks ago virtually. I watched this presentation that I wanted to share with you. The data is unpublished, but it will be published. And it was presented by a researcher at Stanford named Tandy Ai. And they looked at parent and adolescent perceptions of parental acceptance. And it was sort of an intricate model, but I was surprised at some of the findings. So they looked at 25 families that had transgender and non-binary youth who were in the adolescent, young adult age range. And they did qualitative interviews with these families. So they interviewed the adolescent separately from the parents and asked them and explored about pivotal moments in the trajectory of parental acceptance. And then really drilled down more about what happened in the family unit during those pivotal moments. And they discovered a number of pivotal moments, but the two most difficult moments that parents described were when the adolescent first verbalized their trans or gender expansive identity, so the sort of coming out to the parents process. And then again, when the adolescent presented them with an affirmed name and pronouns to start using. And parents definitely felt that these pivotal moments required an adjustment period following that, which is probably not a surprise to those of you who have been through it and certainly is in line with what I observed clinically. And then they asked about the level of parental acceptance during those pivotal moments. And one interesting finding was, regardless of how accepting the parents were, the adolescents consistently felt that they were more accepting than the parents felt they were. And when the level of parental acceptance was actually lower, this division was even broader. And to me, this indicates that parents are doing an exceptional job of really working on this internally, and that they're still projecting a level of acceptance that is reassuring to the adolescents. The other thing they looked at was, how do parents show support? And the parents reported showing support by connecting the adolescent to services or resources, using affirming language, including their name and pronouns, and using gender neutral terms, supporting their authentic gender expression, and providing physical comfort and emotional availability. The adolescents reported feeling supported very specifically when parents used their name and pronouns, and when parents showed compassionate and effective behavior, like hugs and kisses. And I think this may be a disconnect between what parents are doing sort of behind the scenes without the adolescent being aware of it. So we know that that connecting adolescents to services and resources is a really important thing that parents need to do, but it didn't project the support to the adolescents. And really what they need is for somebody to recognize their identity and to show them love. And so once again, I get choked up every time I think about this parent-child dynamic. I want to thank everybody for being here to support their loved ones in this journey, which can be very, very challenging at many different times. I will leave up this information just with the contact info from our different programs, and I think we'll be happy to take any questions at this time, Isabel.
Fantastic. Thank you so much, Dr. Weimer. That was definitely looking through the slides, discovering so much information, and how really what you're doing at UCLA is really the gold standard. So thank you for presenting that. We do have some questions. One that has come up is, where can you find out what should be covered by law in California for sexual reassignment surgery?
That's a great question. So probably the most important resource to know about is that in 2012, California passed the Gender Non-Discrimination Act, which is very broad. It includes non-discrimination in housing, in schools, et cetera, but it also has a specific insurance non-discrimination clause that states that if a service is covered by an insurance for any other indication, it must also be covered for gender affirmation. So for instance, if you cover a hysterectomy because somebody has a medical indication like fibroids, you must also cover a hysterectomy purely for gender affirmation. And then layered upon the California Non-Discrimination Act is, of course, the Affordable Care Act, which really mandates that any program or institution that is receiving federal funds, and that includes payments from Medicare, so that's essentially all institutions, must provide gender affirming care. Now, the problem is that they used that sex clause and not sexual orientation and gender identity. So this has been implemented differently in different states, but in California, it's supported by the Gender Non-Discrimination Act. Now, the devil is in the details, and every insurance policy has made its own determination about what is medically necessary. And so there really needs to be a lot of appeals if something seems like it's medically indicated and might otherwise be covered. Then you're on very good footing for insurances that are based in California. If you have an insurance that is based in another state, so we see this with young adults who might be on an insurance policy from their parents in a different state, the rules in that state might be different. And I think that's really important to recognize. The other thing is there are things that won't typically be covered by insurance that are medically necessary for this population, like hair removal or fertility preservation. And so, you know, we can do appeals and sometimes engage legal advocates in really pushing forward on why something is medically necessary for this individual. There's also a new law that was passed in October of 2019 that many people are still not aware of, that mandates that if a person is going to have medical treatment that will impact their fertility, the insurance must cover fertility preservation. And this was done with a lot of lobbying from oncofertility, so folks who have cancer, but it is very directly applicable to gender affirming care. And the problem is it's still so relatively new that most insurances haven't incorporated it into their policy. But again, it's leaving a space for us to start filing appeals and really pushing insurances to help with some coverage for fertility related concerns.
Thank you so much. That's very comprehensive, so we appreciate it. There's another question that has come up in terms of how would a parent go about finding a therapist for an older child, so someone headed to college next year, and helping them run through potential situations that may come up? The fact that telehealth is now accessible, even if they were going out of state, is a non-issue. So how would someone go about finding that?
So, so the first, I want to answer or comment on the second part first, which is that the telehealth regulations around mental health care are actually stricter than they are around medical care right now. And so it may be actually quite difficult to achieve telehealth services in different states. So I just want to make sure people don't assume that they can continue with a provider. That provider can go through getting licensure in different states or getting temporary licensure, but just don't make the assumption that it will be a possibility. I think it's really difficult to find knowledgeable providers, and our gender health program psychologist, as well as our care coordinator, have lists of folks that we know to be sensitive and knowledgeable. And so reaching out to our gender health care coordinator would be one way to try to get those lists. The other thing you can do is Psychology Today has a provider finder search engine, and that can be a good way. You can search filtered based on your insurance and based on being LGBTQ knowledgeable. and try to find folks who might be accessible for you. And then I would say, I would definitely encourage people to leverage online support groups and networks, because this is a great way that adolescents and young adults share information about their own experiences and kind of can give peer advice to other people.
Thank you. Okay, we have another, actually, just as a follow-up to that question, Dr. Weimer, the coordinator that you're speaking of, would they be, where could we find them within the contact info slide? Is it through the Empower program, or is it through
the Gender Health Program?
The Gender Health Program. Excellent. Okay, thank you so much. Okay, another question from Trish. What type of insurance denial appeal support can UCLA provide? For example, for top surgery for a minor that would have been denied?
Yeah, so we will absolutely go through the appeals process, and we can also do peer-to-peer calls, which sometimes help a lot if the surgeon contacts the medical, authorization folks at the insurance. Sometimes they can get a denial overturned. And then we do not yet, although it's certainly my dream, have a legal advocacy branch to our program, but we do help people connect with legal advocates in the community. There's an organization that you may know of called Trans Family Support Services in San Diego.
Yes.
And they have a wonderful track record in getting some of these denials overturned. And I think the important thing is to recognize that not all of the denials are the same. So we have to look at why it was denied in order to be able to respond to it. So sometimes the denials will say, this person can't have surgery because they haven't been on hormones for a year. And we know you don't need to be on hormones in order to have top surgery. So that gives us a very specific piece of misinformation that we can respond to. Whereas if it's written in their policy that they just don't cover it for minors, then we need to provide them with some re-education about why it's medically necessary for minors.
Thank you.
I spend a lot of time with appeals.
We can tell there's definitely you have a lot of knowledge on that, and it's specific, and so that's really helpful in the way that you're answering the questions, and so thank you. More questions. This one from someone who's personally looking to start hormone replacement therapy in adult. And so what is the first step? Can I meet a doctor through teledoc for a consultation?
Yes. So generally, most of our providers will do a consultation, and really what we're looking at is making sure that your goals for the hormone therapy are goals that we can help you achieve, and then making sure that medically there's nothing that we need to optimize or address before starting hormone therapy. So, contacting the Gender Health Program directly, the care coordinator can tell you about the different primary care providers who are available and where they are, and we can do that first visit by telemedicine. Most of the time, we'd like to have somebody seen in person at some point before starting hormones, just because, we really do want to do a good physical exam. We need to do some lab work. We need to check your vital signs. So most of the time we are preferring to do that unless we have all of that information already from another provider, say at UCLA. And Isabel, I don't know at what point you might want our other primary care docs who are present tonight to introduce themselves briefly. I will leave that up to you.
Absolutely, absolutely. If as a matter of fact, if I'm wanting to in order for us to be able to continue with the recording and the signing, we'll need to keep the cameras off. So probably at the end of the Q&A portion, if that's okay. All right, another question here. What is UCLA Health experience with insurance coverage for top surgeries for kids younger than 18? I think you answered it in part.
Overall, it's been very good. It often takes some blood, sweat, and tears, but generally we get there.
Fantastic. One question here, and I'm just reading through it. Therapist in the South Bay for a child of who's 14 and a half, assigned male at birth with medical risks for hormone therapy, especially regarding cancer and heart. And there's a legal referral when parents do. It was a legal referral when the parents divorced. One of the parents is open to hormone therapy and the other one is not.
California is a two-parent consent state. So if there are two legal guardians, they both need to be consenting to medical treatment. The way that and this situation happens, the way that we have navigated it is, really to try to engage the more reluctant parent in the conversation, because it's very hard to provide information unless you start the conversation and find out what the reservations are. And so because we know the kids do better when they're supported by their parents, our first, second, and third line is always going to be to try to get both parents on board. And that's where we're going to invest our energy. And then, short of that, if it really becomes emergent to move forward with hormone therapy and we have a non-consenting parent, then there are paths to get a court order to start the treatment. And it's never our preference to do so because of the strife that it can bring into the family. But there are legal paths that one can take. But I've had very, good success when we've had one reluctant parent with just working with them and helping them get the support and education that they need. The hormone therapy risks question, I think the first thing I would say is it sounds like probably the starting point would just be to have your child evaluated so you understand where are they at right now and what are even the medical options that would be available to them. And that also might give more specific information to bring your ex into the conversation. This is specifically what we're talking about doing. These are the specific considerations around it. The risk of cancer with hormone therapy is actually not increased. With the one exception of if we have somebody who's assigned male at birth and they go on estrogen, their breast cancer risk will be higher than it was, because being a cis male, breast cancer is quite rare, but still the risk of breast cancer is lower than it is in cis women. And again, I think you would benefit from having somebody really tease out what is your family history and how does that risk specifically apply to this child. But many of the things that are put forward as health risks are not as significant a contraindication as one would think they are. And then in regards to the therapist in the South Bay, I don't have a recommendation off the top of my head. You could certainly contact our program coordinator and they may be able to find someone, or maybe word of mouth from other folks.
Dr. Weimer, we have another question. What about health coverage that has specific age requirements, such as no transgender surgery covered until after age 18?
Yeah, so I think, we've sort of touched on that, which is that we then respond by providing evidence of medical necessity in order to move forward with that. And, I will say that at UCLA, our surgical providers really do want folks to be 18 for everything but top surgery. And so we have not navigated trying to get coverage for genital reconstruction for a minor.
Okay. That's helpful. All right.
And the other thing I'm just going to cast out is the more pressure these insurance companies get and the more times they hear that they're not covering something that's medically necessary, the more it's going to impact policy. So it's really labor intensive and the fight is difficult, but I would encourage people to try to move forward if something is medically indicated.
Perfect. I would encourage everyone, if you have more questions, to please put them in the chat. And at this time, I'd like to invite the other physicians that are part of Dr. Weimer's team at their Beverly Hills office, if I'm not mistaken, to please turn on your cameras and maybe unmute yourself and introduce yourselves. We'd love to meet you.
And let's see. Here we are. Maybe we can go alphabetically. Dr. Delgado, do you want to start?
Sure, I can start. Thank you very much for Dr. Weimer for our presentation, for letting us, for PFLAG for allowing us to be present, and thank you everyone as well that's here today. So I'm Dr. Delgado, and I work both in an office in Beverly Hills as well as in Westwood. I'm family medicine trained, so I see both children and adults. And I do gender affirming hormone management as well as PrEP and general primary care for everybody.
Thank you.
Welcome. Thank you for being here.
Thank you for having me.
Did we lose Dr. Fernandez?
Nope, I'm here.
Oh, you are. There you are.
Sorry, I don't have the UCLA health background.
That's quite all right.
I'm JD Fernandez, also a primary care doctor at one of the Beverly Hills practices. I previously worked at Mount Sinai in New York at the Adolescent Health Center there, where we saw patients from 12 to 23, but here I'll be working on adult primary care, so really great for kind of those transitions of care. And just wanted to reiterate what Dr. Weimer said. Thank you, like parents and caregivers and supporters, because it's just so incredibly helpful. So.
Well, thank you for being here. We appreciate your presence and the care that you're providing your patients, and being here as part of the conversation as well.
And Dr. Punicky.
Hi, good evening, everyone. And again, I'll just repeat and say thank you so much for having us. And I think that this is an incredible community that you have, and I really appreciate the support that you're providing one another. And I'm happy that we can be a part of that. So my training is in adult primary care. So I typically work with individuals of 18 or older. But my training is also, so I'm an HIV specialist as well. And so I trained in New York at a center there and did a lot of co-management of patients who were transgender or non-binary and also had HIV. And worked with them for that. I also do a lot of HIV prevention with PrEP and other options. Just really happy to be here and see all of the great work that you're all doing.
Thank you so much.